So I'm Dr. Sébastien Trincat. I'm a newbie UBE orthopedic surgeon, and I work in Nîmes. Nîmes is a city which is not very far from Montpellier, but the problem with me it's that it's between Montpellier and Marseille. It means that I work between Joseph and Guillaume, between the ice and the fire, you know. Then I had to do UBE. So you all know that biportal endoscopy is the best surgical approach for lumbar spine surgery. You all know that, because otherwise you wouldn't be there. But there is still a problem with the risk of hematoma, which remains, and which is estimated between 20 and 25% of the patients on MRI. But only 2% of the patients are symptomatic. So when I started UBE, maybe 1 year ago, I decided to investigate the effect of a drainage on postoperative pain and on the occurrence of epidural hematoma. Not to publish it, but just to improve the care and the management of my patient. So I conducted a prospective continuous study, including 60 patients, operated on one level with a pressure pump. The 31st patients were drained with a low pressure drain, and the 30 next were not. And they all had the same hemostasis protocol, including Exacil, bone wax, flow thrombine, and controlling blood pressure under 100 millimeters of mercury. Patients with dural tears were excluded, and there was no preventive anticoagulation. Pre and post of pain was self-assessed simply by the patients. And there was a systematic MRI realized either the day after surgery or the day after drain removal, and the hematoma was assessed on an axial slice passing through the disc on MRI. Concerning MRI, this is the picture I was expecting to see. The picture that makes you believe that you are a good surgeon with a clear release and a small hematoma. But you will see that reality was quite different, and that even if it's endoscopic surgery, it's still surgery, and it's a good school of humility. So actually all the patients had a posterior collection with an hematic component. That's why I decided to divide each group, drain or no drain, into 4 groups, depending on the volume or the surface of the hematoma, trying to find a link or a correlation between the pain and the importance of the hematoma. In the drain group, the pre-op pain was 7.6, the post-op pain was 0.8, and the mean drain bleeding was 100 milliliters. On MRI, 97% of the patients had an hematoma taking up less than 50% of the canal. In the no-drain group, the pre-op pain was 7.9, the post-op pain was 1.2, and on the MRI, 40% of the patients had a posterior collection taking up more than 50% of the canal, and 20% of them an hematoma taking up more than 75% of the canal, which was honestly a bit worrying. But paradoxally, there were no neurological complications and only a moderate lumbar pain. Sorry. Talking about statistics, there were no differences between the 2 groups. Talking about pre-op pain, post-op pain, improvement of pain, and in the group of no-drain patients, there were no difference talking about pain between the patient with an hematoma taking up less than 50% of the canal and the patient with an hematoma taking up more than 50%. So now I will show you the 60 cases. Okay, you're following, thank you. No, only 2 cases. So the first one is the L4, L5 stenosis, and you can see on the postoperative MRI that there is a clear release, but that there is an important posterior collection compressing the neurological structures, but without neurological disorders and with only a moderate low back pain. And on the MRI realized 3 months afterwards, you can see that there is a complete regression of the hematoma. The second one is a L2, L3 stenosis above L3, S1 arthrodesis. And on the postoperative MRI, you can see again a compressive hematoma on the operated level, spreading to the 2 levels above. But again, without neurological disorders and with a moderate low back pain. And on the MRI, realized 2 months afterwards, you can see a complete release, a complete regression of this hematoma. So this study has some limitation. It's been conducted by a newbie surgeon with a learning curve of 20 cases when I started this study. There was no volumetric evaluation of the hematoma, and there was a lack of patients in each subgroups to find clinical differences. But still, we can conclude, looking to the results, that the absence of drainage does not affect postoperative pain. It increases the risk of occurrence of an epidural hematoma on MRI. That may be a major problem, but most of them are asymptomatic. There is no impact on postoperative pain. There is a complete regression after a few weeks, let's say maybe 6 or 8 weeks, and there is no need to reoperate, even for encroachment more than 50% of the canal. And as a take-home message, I would say that it's not worth performing MRI with an asymptomatic patient if you want to sleep well. So thank you for your listening. Thanks to the audience, thanks for the organization of this amazing event, and a special thanks to Guillaume, of course, and Joseph, who helped me and supported me in the beginning. Also to Alexandre, but I didn't have the time to draw him. So thanks a lot, buddies.
Thank you. So questions? Anybody has some questions?
You did the MRI, I mean, it's what, 12, 24 hours? Because
let's say 24 hours.
24 hours, yeah.
With when the patient was drained, it was removed the day after, in the beginning of the morning, with the first nurse of the morning. And the MRI was performed 1 day after drain removal. And when there was no drain, it was done when the radiologist was okay to do it, when you have the time, but let's say maybe 24 hours. Why?
No, because I don't know what you're feeling and the feeling of the others, but all of my symptomatic post-op hematomas develop after 24 hours.
More than that, maybe.
Even more. 7
days.
No, not so much for you.
No, I agree with Guillaume, but it's another
early.
Question, yeah.
It's not very early in post-op.
No, I'm agree with you. It's not the same day or the night, but for me, the patient has a very good feeling at the beginning, when for a few days, more than 5, I think, and they come back with the call, I have new leg pain, what's happened? And if you want to have a good night, you don't do an MRI, but if you want to answer to the patient, you do an MRI and say, okay, there is an hematoma.
I did this to evaluate the hematoma, but patients were not so painful in this group. But I agree with you, most of the time, there is a big clinical relief the day of surgery or the day after surgery, and sometimes there is a radicular pain that comes maybe after 7 days, you know, but it is not necessarily linked to an hematoma. In this series, all of the patients were well afterwards, you see. But I had that kind of problem with other patients, of course, that were not in this study, who had that kind of radicular pain coming again after a few days.
What is your practice now?
Dr. Christini said no drain, so no drain.
But I said, put some drain.
No, my practice now, in the beginning I had the feeling that they were more painful without a drain. That was my feeling. Then I said, so maybe I have to put a drain to improve postoperative pain. But in the end, when you look at the result, the pain is the same. And the hematoma, if it's not symptomatic, I think it's not a big deal. You just have to warn the patient that he doesn't have to hesitate to call you if there is any problem. So, but I don't put any drain now.
Okay. Congratulations for the presentation. Was very clear. When you have an symptomatic hematoma, with radicular pain or back pain? How do you treat it?
It depends on the symptoms. If only a pain, medically. I started in January 24. I didn't yet reoperate patient for hematoma. And when there is back pain or radicular pain coming back after a few days, usually it regresses with corticoids, but it's not linked to the hematoma. And most of the time in my practice, when they keep a radicular pain, it's mainly a technical problem with an insufficient release of the foramen, for instance.
Thank you.
For us, at the beginning, we reoperate the patient because we don't know if the patient could have some problem at the end, but now we don't reoperate it, just put some corticosteroid and medical pain is okay.
One last objection, big objection. If you have a patient who is with really bad symptomatology and he does have an MRI with a big hematoma, it's not one chili pepper.
I'm sorry, it was a what do you say? 3. I put 3 in the beginning. And then I reminded the presentation, I said, no, maybe 3, it's too much. Thank you.
Depends on the chili pepper.
Exactly. Thank you.
Thank you.